So good morning, everybody. Thank you for joining us again for Monty Hart. This week we have a structural topic on mitral edge-to-edge repair and which device for which patient. It's a real pleasure for me to present Maurizio Taramasso from the Heart Centrum Hisland in Zurich in Switzerland. It's especially a pleasure because Maurizio and I go back a really long way, and I remember him as a fellow. He's one of the surgical fellows who decided to train in the cath lab. And I remember spending a lot of time training you how to move catheters and even do PCI, I think, Maurizio, we did together. And so when you see someone who was a fellow who's gone on to be extremely successful, he's a cardiac surgeon as well as a structural heart interventionist. He's world renowned now. Everybody knows who Maurizio Taramasso is in the field of structural heart. He's a world expert on mitral tricuspid and aortic interventions, and is extremely well published as well. So it's just been an honor and a privilege for Maurizio for me to see you grow. This session is CME accredited, so I want to make you all aware that both me and Maurizio do have conflicts of interest. We do consult for companies that produce mitral devices, including edge-to-edge repair devices. Our consulting usually relates to helping companies design what the next generation device is going to look like, how to make devices better. It's not income for talking or to perform clinical studies. It's more really advising and looking forward as to how these devices will be better in the future. And we may discuss some off-label usage today. If we do, we will let you know. So Maurizio, without further ado, thank you so much for joining us.
Thank you, Azim, for the kind introduction and for the invitation. Really, before starting, I would like really to confirm what you said. You are one of my mentors, and I would not be here without you and without your mentorship in both clinical and also scientific fields. So thanks again, and it's really a great pleasure to be presenting this topic at your lecture at Montefiore. It is a, let's say, interesting topic, which it's really prone to discussion because nobody has the correct recipe, which device for which patient. We have different devices. Two of them are commercially available, but at the end, operator preference is playing still the main role. And we may discuss a bit at the end, which is your view and which is my view. And as you said, we have some disclosure, and here I'm reporting my disclosure. And I will start telling that there is not only transcatheter edge-to-edge repair for the mitral. So today we will focus on which edge-to-edge device to use in which anatomy, but there is much more and even more to come. So maybe next year we will do which device for which patient, not only for edge-to-edge, but for, let's say, all the field, all the portfolio of mitral, including repair, annuloplasty, and replacement, and even combination of different devices. But today we will focus on leaflet devices, namely on edge-to-edge repair. And I will start a bit with an overview of the two commercially available devices in US and in Europe. And then I will try to share with you my experience on which device I prefer in which specific anatomy. Obviously, we all know the MitraClip that nowadays is available in the fourth generation. The fourth generation has been a big implementation as compared to the third one. We have now 4 different clip sizes. So even inside the same device, we may discuss about patient selection, which clip sizes to use in which specific anatomy. We can grasp the leaflet independently, or we can optimize in an asymmetric way the leaflet grasping. Well, the device preparation is slightly easier, and we can monitor it live, the left atrial pressure variation. So there are several implementations. I think the most important are the first two, so the different clip sizes and obviously the control gripper actuation, so the possibility of independent grasping. I will not spend so much time on this because this is barely obvious, but I mean, here you see the two different devices. We have shorter devices and longer, and with both we have the more narrow and the wider configuration. Having different devices and being able to select a tailored one according to the anatomy obviously allows us as operator to reduce with one single device the most the mitral regurgitation. So if we are able to use one XTW device, which is the long and wide device, actually with the same anatomy, we may reduce more as compared to a shorter or more narrow clip. Obviously, we cannot always use the large and wide and the long and wide clip, and there are not that many clinical data to guide. This is a kind of table to help us in selecting based on consensus expert opinion. The most important is the leaflet length. We should not use a long clip if the leaflet are not long enough. We need to have at least 9 millimeter or 10 millimeter of length of the leaflet inside the clip. So if the leaflet is shorter than 9, we should not use the XT configuration or the XTW. Then obviously the extension of the jet will play a role, and also the valve area. So the smaller the area, the higher is the risk of induced stenosis if you use a long clip or a large clip. But again, there is a lot of discussion also in this field, and there is no consensus on which MitraClip to use in which different anatomy. But it's good to have more options, especially if we need to use more than one clip in some specific anatomy. Regarding the result, having now the Gen 4 with different clip sizes and the possibility to optimize independently the grasping, we translate this in better result in terms of efficacy, but also in terms of safety. You may see that the really good result, which were obtainable, achievable with the Gen 3 in the expand, are even better now, even if it was difficult to ameliorate, but they are slightly even better in terms of 1 or less plus reduction at the, residual MR at the end of the procedure, with the possibility of select the device and with the possibility to optimize the grasping. So in 91%, we can achieve 0 or 1 plus MR. This is coming from the Expand G4 registry. So this is not a highly selected population. This is more or less real-world population from a post-commercial registry. And obviously this translates in improvement in quality of life and symptoms, and in safest profile. Basically, if we have better efficacy, we may have also better safety, especially in terms of single leaflet detachment, having the possibility to select the different anatomy, reduce also the chance of having leaflet detachment, and having less MR translate also in basically less hospitalization and less mortality at 30 days and 1 year. So better device translate in safer profile due to obviously better MR reduction, but also probably to the fact that they are more user-friendly and they are more forgiving. And here you see the efficacy and safety profile of Gen 4 device compared to Gen 3 and previously used device in the TVT registry and the Access U, which are let's say the second generation devices. Actually, an extremely important improvement, not only in safety, but also in efficacy and in device time. Having basically larger and longer clip allows us to use less clip overall, and this translates in a shorter procedure and easier procedure. Few words regarding the Pascal system, which has recently been approved for DMR by the FDA. So now this commercially available also in US for DMR cases. The concept is the same. So it is a transeptally delivered device, transcatheter device to perform an edge-to-edge repair of the mitral valve or the tricuspid as well, but today we will focus on mitral. The device is slightly different. It's a nitinol-based device, which is done to stay close. So the MitraClip is done to stay open, and we have an active locking mechanism to keep it closed at the end of the procedure, and we need to check that the locking mechanism is functioning. The Pascal is a nitinol clip system which stay closed, so there is no active closing system. Basically, the Pascal, if you put it at the blood temperature, stay closed. It's really elastic, more elastic than the mitral because it's made on nitinol, and there is a spacer between the two pedals, and this will translate most likely less tension on the leaflet. I will show you some example. There are two device configuration. There is a bigger one and a larger one and a smaller one. The catheter is 22 French. There are 3 components. There is a guide sheet, the steerable catheter, and then the implant catheter. This is quite similar to the MitraClip catheter, but there is no the locking system. So basically we can rotate the three devices 360 degree one with respect to each other. And this allows us to have, let's say, to somehow adapt the trajectory also in some specific situation, like really big atria or really small atria. Could be sometimes a disadvantage, but sometimes an advantage. Here you see the two devices, the Pascal P10, which is the classical one, the first one which was available, which is larger, and it has a bigger spacer. And then there is the Pascal Ace, which has the same features of independent clasping of the leaflet. There is the same features of having 19-hole-based device, but it is delivered with a smaller spacer. It's more similar to a MitraClip, I would say. Here you see more specifically the difference of the two devices. You see that the main difference is the spacer, basically. The spacer is bigger in the Pascal P10, and it is smaller in the Pascal Ace. Here you see also one really interesting safety features of the Pascal, which is available for both, which is the possibility to elongate the device. And this is particularly appealing if we need to treat commissural lesion. So if we go within the chordal apparatus and we want to go back, sometimes with MitraClip we may get entangled and could be problematic to come back without damaging the tissue or even impossible. With Pascal, this is much easier because you can elongate, and we'll show you an animation in a few slides. And this make, obviously, the removal of the Pascal from the subvalvular apparatus, I would say, much easier. Here you see the comparison of the two Pascal P10 and Pascal Ace. Nothing really different from MitraClip in terms of procedural step and concept. There is a steerable catheter that allows us to steer in a coaxial way towards the mitral valve coming from the septum, and then we can capture the leaflet independently. You see really well the difference in terms of spacer between the Pascal P10 and the Pascal Ace. We can not only clasp the leaflet independently, but we can also optimize the leaflet capture exactly as we do for MitraClip G4. And here you see an example of P10 implantation in 3D. You see the spacer between the leaflet. And this is important for us to understand because at the end, especially if we use the Pascal P10, so the bigger one, we don't do really a leaflet-to-leaflet approximation, but we approximate the two leaflet to the spacer. And this translates, as you see here, this is not based on clinical data. This is, let's say, finite element analysis. So it's where you see that there is less tension of the leaflet. If you have the spacer in between, you approximate the two edges of posterior and anterior leaflet to the spacer. So you have leaflet, spacer, and then again leaflet. So at the end, you perform an edge-to-edge by pulling less on the leaflet, and the result is a slightly bigger residual valve area of the two orifices, and also possibly a lower gradient. So I think in valve where there is a risk of stenosis, having the possibility to choose a Pascal could be helpful. And paradoxically, if we use the bigger Pascal, which is the P10, where the spacer is bigger, we will have more residual area. So we maybe tend to think that if we use the small Pascal, we will have less gradient, but actually, even if there are no data at the moment, but actually it is the opposite. If you have the bigger spacer, we pull less on the leaflet, and at the end, the residual area will be bigger and the gradient should be lower. Here you see what I mean when I say that Pascal is really elastic because it's a 19-hole based. So also the elasticity of the implant is pretty much appealing if you have valves which are really stiff or calcific or at risk of stenosis. And here, I will skip this. This is just the independent leaflet capture, which is the same for Pascal and MitraClip. This is the elongation of the device that I was mentioning you before. If you get entangled in the chordal apparatus because you are targeting P1 or P3 area and you are not able to go out, you can just elongate the device, and usually this makes the removal of the device from the chordal apparatus extremely easy, and I would say really safe. Here you see how the elongation looks like in fluoroscopy. And here you see the result. These are the results from the first class study. The results are somehow comparable to the one obtained with the clip in the overall population. There is a sustained MR reduction in both functional and degenerative mitral regurgitation in well-selected patient. Recently, I think just a few days ago, and Montefiore group was present in this publication. On JACC, it was published also the result of the Pascal in, let's say, complex anatomy, for example, multiple jets, small area, Barlow valve, commissural lesion, and actually they are extremely good also. So not only in P2 flail, P2 lesion, but also in a bit more complicated lesion. This compare pretty much well with other devices. Regarding direct comparison between MitraClip and Pascal, one really important element is that the catheter of the Pascal is less stiff than the one of the MitraClip. And if we know that if we do not release the tension on the MitraClip before the final release, we may have some surprise. Sometimes the result after the release improve, sometimes it worsen. With Pascal, this is less visible because usually the catheter is less stiff, so there is less tension on the system. And this is a non-randomized comparison showing that before and after the final release, there is less variation with Pascal as compared to MitraClip. But again, this is single center experience. There is a randomized comparison. The trial on functional MR is still ongoing, but at TCT, the result of the CLASP 2D randomized trial in degenerative MR, which was just, let's say, anticipating the FDA approval, was presented, and actually Pascal was not inferior to MitraClip in MR reduction in degenerative non-complex anatomy. So the patient that I showed you before in the complex anatomy were outside the study, were not randomized. And we may say that the results are really promising and for sure non-inferior to MitraClip. And now I move to the most interesting part, but also the most controversial part of the presentation. I showed you the two devices. The two devices are excellent. We can achieve excellent result with both if we know how to use it. But if we come to the question, which device for which patient, having both the device available, then this is a matter of discussion that can last for hours, because at the end, there is this direct comparison where in DMR, one is non-inferior to the other one. But at the end, still, there is no flowchart to tell us which device perform better in which anatomy. So what I will tell now is my personal opinion based on my clinical experience. So you may have a total different opinion. And if this is the case, I'm really happy to discuss with you at the end and to learn from your experience. My personal opinion is that obviously most of the anatomy, I put more than 90% here, but let's say that most of the conventional anatomy can be treated with both platforms, so with MitraClip or with Pascal, with comparable good and predictable result. I would say that it's somehow similar to the TAVI field, which is totally different, but most of the anatomy we can treat with balloon expandable or self-expandable valve, achieving really good result. And obviously, operator experience, operator preference, and also logistic of the center, so the availability of one of the other device will play a role. So I would say that they are, I would say, complementary or changeable in most of the anatomy. But then there are some specific anatomy which are unusual. Some of them are even off-label, as we mentioned at the beginning, where I personally think that there may be some advantage of using one platform compared to the other one. And here I report you just some examples. There are more than these, obviously, but these are some examples that are unusual, but not so unusual. We see quite commonly this anatomy. And I think in this specific anatomy, we may, or at least I prefer to go for one device or to the other one. And now I will go through this aspect. Red is the Pascal and blue is the MitraClip. Let's start with Pascal. For example, commissural flail. This is a isolated P3 flail, so really commissural lesion. You may see also in the X-plane. It's a small flail, but leading to really severe eccentric MR. Obviously, you can treat this anatomy really easy and with excellent result, also with MitraClip. But personally, having both and having experience with both, I think this is an anatomy where if I use a Pascal and specifically a Pascal ACE, I feel more relaxed because I don't have any concern to get entangled in subvalvular apparatus. Again, you can use both, you can have excellent result with both, but in a specific anatomy like this, I rather prefer to use Pascal ACE because of the elongation possibility to get free from chorda in case of need. Here is how the lesion looks like in 3D. So really commissural medial lesion. And in this case was not needed to elongate and to go out, because with one single clasping, we were able to catch the leaflet and getting a good result with one single device. So really commissural lesion is an anatomy where I personally think that Pascal ACE would give us some advantage. Another example is based on the discussion that I said you before, so the presence of the spacer and the elasticity of the nitinol. If we have a calcific valve, so with calcific leaflet or even with calcific annulus, with small valve area and risk of, let's say, damaging the leaflet or risk of gradient, I think, so here you see the 3D, sorry. So the valve looks quite small. There is a baseline gradient of 4 to 5 millimeters of mercury. Obviously, there is also MR, so it's not only, but the valve looks small and the leaflet, they do not move really much. And there are also calcification of the valve. In this case, I used a Pascal P10, which is the bigger one, the one with bigger spacer, because I wanted to have actually less tension on the leaflet to reduce the risk of stenosis. You may immediately see that the bigger spacer give also you more shadowing, so sometimes it's more difficult to see the leaflet if you use the P10. But in specific case like this, nobody's using P10 anymore. It's really rare to use P10, but I still think there is a room for P10 in case like this. And actually, we put one device in the middle of the valve, and with one single device, we were able to get a good MR reduction with 5 millimeters of mercury of gradient. So this is a case at high risk for stenosis, where I think Pascal could have some advantage, specifically the P10 with the bigger spacer compared to clip. On the opposite, for example, if there is a Barlow valve with a lot of tissue, I prefer to go for MitraClip, and I prefer to use the large, so the wide and long MitraClip, so the XTW. This is an easy Barlow. There is no clear flail. There are no multiple jet. The main jet is A2P2. So this is, Barlow is not an anatomy we treat so often with edge-to-edge repair. But, I mean, there are many old patients with Barlow, so we see those patients. And if you have A2P2 jet, the result that you can obtain is extremely good. And in case like this, I personally want to have a lot of pulling on the tissue. I want to grab a lot of tissue and to try to stabilize also the annulus. So I definitely prefer MitraClip, and my device of choice in case of Barlow is definitely MitraClip. Even if you can use also Pascal, I would use a Pascal ACE because you have more pulling on the leaflet, but I rather prefer clip. And in this case, we use one XTW. Obviously, you need to have a really good leaflet insertion in Barlow, in all the anatomy, but especially in Barlow, you want to have a nice grasping. And with one single device, we were able to obtain a good result, one XTW. Another example, which is an off-label use, but is not that uncommon, we see relatively often patients with SEM and severe MR. And here you see there is the DMR, degenerated mitral valve for sure. There is also hypertrophic septum, and there is significant SAM. So there is for sure an anatomical component, but there is also let's say, hemodynamic component inducing MR, and there is severe LVOT obstruction. You see that the tip of the anterior leaflet, the body of the anterior leaflet is protruding during systole in the LVOT, and there is definitely not only severe MR, but also severe LVOT obstruction. And in this specific anatomy, again, I want really to bring the anterior leaflet out from the LVOT. And in order to do this, I want to pull a lot on the tissue and to grab a lot of tissue. So this is a specific anatomy where I prefer to go for MitraClip. And again, I prefer to go for XTW. And again, since despite this is not usual, most of the time those patients are surgical candidates and they go for surgery, but still we see those patients and you can really achieve good results. You see now there is really, the LVOT is free. There is no anymore leaflet in the LVOT, and there is also minimal residual MR. Again, you can do it also with Pascal with really good result, but I think also in the view of long-term result, bringing a lot of tissue and pulling a lot is probably better. Another really uncommon anatomy where I prefer MitraClip is if you have tortuous venous anatomy. So, for example, if you have really severe scoliosis, I want to have a stiffer catheter, a stiffer delivery system. So if I can predict severe tortuosity, I rather prefer MitraClip than Pascal, which is obviously less stiff. So there are advantages. So more predictability before the release, but there are also somehow some disadvantages, like in terms of really tortuous venous anatomy. It is rare, but it may happen. And so this is a bit my personal recipe. I don't know what is your opinion, and I'm really happy to discuss with you if you have any other specific subset of anatomy where you prefer one or the other one, or if you do something which is totally the opposite. I would like just to thank you for the attention. I think it was really an interesting topic, the one you gave me, and it was anyway extremely interesting for me to try to build a kind of algorithm to.
Exactly. No, I mean, Maurizio, thank you so much. The reason we asked you for this topic, because it's something we struggle with. There's no clinical data, right? And even the company doesn't know, it seems.
Absolutely.
I'm surprised that, if you look at MitraClip, there have been, 180,000 MitraClips done in the world, something like that. And still, depending on the day on which clinical support person you have in the room, they'll tell you something completely different for the same anatomy. The one day they'll say, no, do XTW. The next day it's NTW. So it's confusing. Could you put up your last slide again, Maurizio? Because I think I really like this slide. I want people to see this slide, because I think I do exactly the same as you in specific. I think in most scenarios, it's probably the same. You can get away with both devices. But I think these are the scenarios where also I prefer one over the other. The only other ones I would add to this maybe is even if it's not a commissural flare, but it's a very cord-rich area that I want to go grasp in, I'm probably going to choose Pascal over MitraClip. That's the one. And then the other one I would put on here that changes my choice is low transeptal height. So if we have Edwin Ho, so I'm very lucky, you know Edwin very well. So Edwin always on his pre-echoes will measure the transeptal height, okay? And if he says to me, Azim, listen, I'm only getting 3.5 here, I'm not going to try with MitraClip then. For me, that's an indication to say I'm going to use Pascal, because the fact that the catheters are not keyed together, you don't need straddling, you can really overcome low transeptal height a little bit better. So that's the only one I would probably add here. That we kind of have used to choose between Pascal and MitraClip. So before the fellow, actually, I have one more question about actual clip selection, but I'm going to let the fellows go, because I'm sure they're going to ask better questions than me, and then we'll come back to you. Okay, so you see we have a very international, the structural fellows are very international here. I think we're representing, 5 different countries. We have Italy, US, Germany, France. Julio is not putting his thing on, but we also have Spain and South America. So we have a very international faculty for you to ask you questions, Maurizio. Go ahead, Andrea. I see you first on the list.
Hi, Maurizio. It's a pleasure to see you here.
Hi, ciao.
Ciao, Maurizio. I have just a question. You said that the more leaflet tissue, the better is for long-term results. But this may also translate into increased rates of leaflet injuries at long term. Of course, with G4, when we will have 1 year results, we will know more. But do you have any experience? What do you think about this? Because we are using, as you showed, different clips for different patients. So we cannot change that. But do you have any specific recommendations where we are clipping patients with large devices?
I think the increasing of leaflet tearing is more due to the length of the clip rather than the wideness of the clip. I think in general, if there is a really large annulus, so it's really important the tension that will be at the end on the leaflet after clipping. So paradoxically, if you have a really large annulus, you would like to use more longer clip because it's obviously easier to grasp. But this is not a really a good idea because at the end you will have a lot of pulling because the longer arm will pull a lot on the leaflet. And especially if you are not perfectly symmetrical, if you are not perfectly, let's say, in A2P2, like 12 o'clock and 6 o'clock, but you are slightly clockwise or not perfectly perpendicular to the line of captation, you will have an asymmetric distribution of the tension. So there will be more tension on one leaflet than to the other one. And if this tension is too much, you can really see leaflet tearing within 30 days, maybe not immediately, but at follow-up you may see. So if you are in this situation where you have a really large annulus, I would recommend, and I personally prefer to use NTW, even if it could be more difficult to grasp because you have less pulling on the leaflet, so less tension on the leaflet. I want to grasp, especially for FMR. While having the wide one, so the W, translating a better distribution of the tension, because at the end, for each millimeter of tissue inside the clip, there is a kind of amount of tension. I think we can measure it in Newton. And if you have a larger surface which is inside the clip, this Newton will be distributed on a larger surface. So I think if you are in a, let's say, afraid of too much tensioning, I think NTW is a good device. And in doubt, if the valve is big enough, put a second device. I had recently, it was in tricuspid, last week, it was a perfect result, but I put this clip really in the middle of the valve. And I could see there was a lot of tension because the annulus was large. And then I was struggling. I asked the company, I wanted to put at the end, I didn't put a second device. And like 5 days after, one leaflet went out. And I was 100% sure the grasping was perfect. So I had full leaflet insertion. This was just due to the too much tensioning. So if you are in doubt of too much tensioning, put a second device, because if possible, I mean, if there is enough space, because then you will have better distribution of the tension on two devices. There are no data, but this is something that we see in the clinical. So not only leaflet tearing, but also leaflet.
So Marisha, I want to bring that up with the SLDAs, what you just mentioned, because we've also seen that, and we've seen it we've had SLDAs in cases where we had so much leaflet in, because nowadays with independent grasping, I don't know about you, but if I have any doubt, I optimize. I'm optimizing maybe 90% of the time. Okay, just to be sure, especially the posterior leaflet or in mitral and the septal leaflet in tricuspid. Yet you still, in cases where you're sure there's enough leaflet in, you get SLDAs. And I do think that a lot of those SLDAs are not the leaflet slipping out, but exactly what you said. We put too much tension. And if you had to actually remove that clip surgically, I think you'd still find some leaflet left inside. I think we're almost tearing a piece of the leaflet off sometimes.
Yeah, absolutely.
Yeah.
I totally agree. And I don't know if this is the recipe, but maybe putting a second device, you have two clips holding the tension rather than one, and maybe you reduce.
Maybe. And I think the other thing you mentioned is when you have these very long leaflets, sometimes you get a lot more of one leaflet in than the other. And so there's this asymmetric pulling. And I also worry about that, especially when you release the clip and then you suddenly see it's biased anterior-posterior because you've pulled more anterior in than posterior, for example. Those also tend to worry me a little bit long-term. Anyway, we'll move on. Matteo?
Hi, good morning, Dr. Maurizio, Dr. Tamarasso, scusi. I just have a quick question about the differences in grasping between the two. We know that the Pascal has just one teeth to grasp, and then the MitraClip has some more. For primary MR, maybe there's differences, and a surgeon like yourself, maybe that's felt these leaflets in their hands, can talk about maybe the friability and how they grasp.
Yeah, for sure. The mechanism of capture of Pascal is much gentler, so much more gentle. I mean, at the beginning, when I put the first time the one Pascal in my hand and I tried to open, I said, this is not gonna last because it's so easy to open. It is really gentle, so it's really gentle on the tissue. But obviously, the clinical data are totally different. If there are any, I mean, we don't have high number enough to talk about to compare durability, but in the CLASP 2D randomized trial, there are some maybe better durability in Pascal. I mean, you cannot compare, but for sure we cannot say that the single leaflet detachment in the long-term durability is less in Pascal because you have more gentle grasping. Regarding the grasping during the procedure, no, you need to have full leaflet insertion with both. Again, if you are in doubt of leaflet tearing because of calcific valve, or I would rather go for Pascal because it's more gentle, but the mechanism of grasping, let's say there are no specific technical trick that you need to take care of during grasping. You need to really see the leaflet inside the clip, and you need to have enough tissue capture, otherwise you risk leaflet detachment with both. But for sure, the Pascal is much more gentle.
Right.
Thank you.
Sebastian?
Yes, thanks, Adim. Hi, Maurizio. Great to see
Hi.
you. Great presentation. I have a question regarding your take on the CLASP 2D registry that you showed and that has just been published. I mean, you show that these patients benefit functionally, but you can also see that I think it's 44% of these patients had residuum are moderate or worse. So what do you think? Should we accept these results in patients with complex anatomy, or are there some maybe patients with too complex anatomy for TEER that we should consider for replacement, or
Definitely, yeah.
transapical, or wait for transeptal devices? What's your opinion?
Definitely, yes. I mean, we all, let's say a high volume center or high volume operator feels confident to treat also over difficult anatomy, over complex. So there are always some cases that at the end we said, probably we should have considered something else. And you should probably not accept really this kind of complex Barlow with multiple jet, where you can get acceptable result, but not really good result. Those patients are the one when, obviously, if surgery is feasible, we may consider to go for surgery. And if TMVI would be widely available, we should definitely go for TMVI, especially in functional etiology. If you have extremely retracted posterior leaflet with extremely eccentric jet and large annuli, probably those are the cases where even if you can grasp the leaflet, you can get acceptable result, then they come back with recurrent MR. And these are definitely the case for replacement, whatever transapical or transeptal. But at the moment, unless you can enroll them in a trial or unless you are in a really high volume center, and I mean, logistically is not something that you have in-house. You have a patient today, you can do it tomorrow or even not next week. It has to be organized. And therefore, at the end, I think it's reasonable also to treat some anatomy which we already know that we are not gonna obtain a perfect result, but for sure we should not over-treat them. There is this from Edwards is like a traffic light, green, yellow, and red, but also from Abbott there is easy, medium, and off-label, let's say. In the third column, everybody of us is treating those patients, but we should not exaggerate. At the end, edge-to-edge is a great tool, great therapy, but we have to acknowledge that it has some limitation. We cannot treat all the patients. Sometimes it's the only thing that we can do, and we accept compromise, but we just need to be aware of this.
You know, the other thing I would add, Sebastian, you have a large database choice, and you have the choice registry in your hands. And I would urge you to look at something. If you look at the choice and you look at patients who are in the red category based on the heart valve collaboratory for edge-to-edge repair, okay, I bet you that a lot of those patients are also at baseline not good TMVR candidates, right? Because it's the same anatomies, right? So if you look at it, if you think about who are the patients who are in the red, it's patients who have TMVR with multiple jets, a Barlow type valve. Those patients often have small ventricles, right? And small LVOTs. It's patients with calcium and calcified leaflets who are not good for edge-to-edge. But some of those are also not good for TMVR. There's small ventricles. There's not a good anchoring zone. They're not going to expand. So there's, you know, even though we love to say that, if you look at the Pascal 2D registry, it's essentially patients from the red zone that in the past, we would say they're off-label for MitraClip. And that's what Edwards was looking for. They're looking for a category of patients where they can say Pascal is better, okay? And then all of us, we talk about this toolbox approach where we say, but those patients, we know the results are not great. So we should do TMVR, but they're actually not good anatomical candidates for TMVR. And the more I do this, the more I realize that, we have like 3 clinical studies here. Maurizio does, you do back in Germany. And we've been looking for patients to put into our TMVR clinical studies, and we can't find anybody. You know why? Because all the patients we send are patients in the red category. And so I realized if I actually want to do TMVR and learn about TMVR, I have to send patients who are in the green category for edge to edge, maybe some in the yellow, but those are the same patients who are probably going to be the easiest patients for TMVR, right?
Yeah,
and
totally.
so that's the challenge.
Yeah.
Guilam, I don't know if I'm pronouncing, tell me again how to pronounce your name properly, Dr. Bonnet.
Guillaume, Guillaume, it's perfect.
Okay, good.
Thank you for this amazing lecture. We learn a lot. Really, thank you, Mauricio. Just one question on the Barlow case. You use only one clip. I would like, in the same idea to do optimization. Now we know that we try to have the best results, as we discussed already. Could we use a second clip to maximize the best results if there is no risk of gradient to prevent, long-term evolution, even if we don't, we already have a low mitral grade of regurgitation? What is your opinion on it?
Sure, I think yes, excellent question. It's really rare that you do Barlow with one clip. Usually, you put 2 or even 3 clips depending on the anatomy. So the case that I showed you is quite unusual. But in this specific case, I look at the mobility of the clip. If I'm happy with leaflet insertion and with the MAR reduction, and in fluoroscopy and echo, the clip is stable, I don't go for stabilization. I do put a second clip. If there is same situation, so no gradient, no residual MR, but I see the clip moving too much, then I go for a second or even for a third. Third is rare just for stabilization, but definitely I would put a second one to stabilize, even if, there are no data on this, and the company, they usually tend to say that you should not do it. But I think if you see the clip which is moving a lot, it makes a lot of sense to stabilize it, absolutely. Not only in Barlow, also in some cases of DMR with big flail, and where you still see a lot of movement because you have more posterior than anterior, or the opposite, I think second one. Also for the reason of distributing the tension, if you see that it's moving too much, that means that one leaflet is more under tension than the other one, and you may still have some leaflet tearing in the long term because you have, so yeah, definitely. Second clip to stabilize.
We have as a rule here, we kind of, we always start with, if we talk about MitraClip with a W, whether it's NT or XT, unless we're going really in the commissure. And our rule has generally been with a degenerative, start with XTW, with a functional, start with NTW. But when I look around and I speak to colleagues around the world, I see some colleagues, even in FMR, they start with XTW if the posterior leaflet's long. What's your approach? What do you do with DMR versus FMR?
We have a similar approach. In DMR, we always, most of the time, we start with NTW unless it is really a commissural lesion, and then we prefer NTW. In FMR, at the beginning, I was always using quite liberally XTW if the posterior leaflet was long enough, so more than 9 centimeters. Now, I don't know why, but I tend to use more NTW. Because I have the impression that in FMR, if you are not extremely careful during the closure of the clip, I see that some leaflet during the closure may slightly go out, and then you have to open again. And this doesn't happen with NTW, and you have excellent result with NTW. So still, if I see the leaflet is really long, I go for XTW. So it's not a dogma that NTW, XTW, but I definitely prefer more XTW for FMR and XTW for DMR, as you do.
Okay, okay, great. Julio, and I think I see next to you Claudia as well. Claudia, Julio, go ahead.
Thank you, Asim. Thank you, Mauricio Taramasso, for this wonderful talk. I have two questions. One of them is in patients with large atrial septal closure devices, which do you think TEER device is best? My second question is, in your personal experience, do you have any cutoff point of thickness in the leaflets that determine if some patient is high risk for mitral stenosis? Because as we know, for example, in patient with native mitral stenosis, the score Wilkins predicts the successful of valvuloplasty, percutaneous mitral valvuloplasty. But do you have any cutoff point for this?
So regarding the first question, I don't know. I mean, I've used only MitraClip in patient with previous ASD device, and but I don't, and I try to go. I mean, there are some reports you can dilate the ASD device and go through but I don't do this. I try to go to find another spot. We've been doing, or even patient with multiple ASD, you can find a spot, even if it is not the best, where you can puncture the septum and go through, avoiding the device. But I've been doing this only with MitraClip, so I have no experience with Pascal. I think you can use both. I don't think there is one over the other one which is better. Regarding the second one, obviously, no, I don't have any specific cutoff, and I don't think there are any specific cutoff of thickening of the thickness of the leaflet. What I look is the mobility. I mean, if the leaflet, they are not really movable, even if the valve area is big, I always look at the, let's say, the subvalvular movement of the leaflet, how much do they open below the annulus. And if I see that the opening is not that great, and but again, there is no a number, it's just a qualitative assessment. And if I am in doubt of risk of stenosis, I rather prefer Pascal P10 for the reason that we have been discussing before. But no, I don't use any specific cutoff.
You know, we recently had a couple of cases, maybe Julio is referring to that, with thickened leaflets, where with Pascal, you could see almost felt like the arms didn't close completely because there was so much leaflet in. But also, we also try to figure out what to do in these patients with small valve areas, valve area below 4. We enrolled some of those in Pascal 2D. Now that Pascal's available, we've been using Pascal. And recently we had 2 cases that were interesting. In the one case, we started with ACE, thinking small device, less gradient, and the gradient went very high, above 10. And we changed to P10, and the same thing happened like you mentioned. It was much better, the gradient, with a bigger device. And then the next case, which was more recent, we tried both, P10 and ACE, and they both gave gradients of 12, 14. And so we left the patient with nothing. Sure. And it's hard to, when you look at the 2 cases, say there was something very different between the 2 anatomies. Maybe, the second one had a little bit more leaflet restriction, but I think, yeah, it's still a challenging area, those. And the problem is neither of those, the patient we took the clip out is not a candidate for a trial because the patient is on dialysis. So we can't get them into any trial. So it's, you're often stuck with these patients, but it's a great question. Claudia is one of our imaging research fellows who's here she works with Victoria Delgado, and I'm sure she has some great questions. Claudia?
Hello, thank you very much for your talk. I would like to ask, in case you are planning to use 2 devices, due to the Pascal being larger than the MitraClip, wider, would you prefer to use one or another if you could choose just from the beginning?
No, actually, let's say the chance of needing 2 devices is not something that make me prefer one of the other device. I look at the leaflet, I look at the valve area, I look at the calcification, all the aspect. But well, if I'm already planning to put 2 devices, probably I'm gonna use a Pascal ACE if I go for Pascal. I'm gonna start anywhere with XTW if it is a DMR case, and maybe with NTW if it is a FMR case, but I'm not preferring one platform over the other one if based on the, let's say, wideness of the jet or the need for a second device, even because most of the sometime, I mean, you are planning to use 2 devices, and then with one you have already a good result. So it's not always so predictable to 100% predict when you need one or when you need more than one. Most of the time, yes, but not always.
Yeah, I agree with you. I don't think we choose Pascal versus MitraClip based on the need for multiple devices, but I do think we do change a little bit our selection. So if I'm doing a Pascal case and I think I'm going to need multiple devices, in my head I sometimes go, should I try a P10 first and just see what I get with a P10, or should I try for 2 aces, right? Because I worry about putting 2 P10s next to each other, even though we have, and we've not had issues. I've put 2 P10s next to each other but in a big valve with DMR, not in a small valve. But I think for MitraClip, I think we all do this. We all start with an NTW, XTW, right? And if you need another one, you then put a narrower clip next to it, usually. It's rare that you put 2 XTWs next to each other, in general. Just because, again, you're worried about, you have to have a big valve to put 2 XTWs next to each other. I don't know, Mauricio, you do the same thing, I guess, right?
Yeah, usually yes. Also because if you put 2 XTW, the body of the clip is somehow bulging. If I want to go really close,
it's hard, yeah.
You cannot. It's harder to go really close because you have the wide part of the clip. So it happens. I've done, I would say, several times to put 2 XTW, but if I want to go really close, yeah, I put then a narrow one. Absolutely.
Great. I'm sorry we're inundating you with questions, Mauricio,
really
but
nice.
you can tell.
Or it was not boring, or it was not clear at all.
No, it was not boring. It was not boring. Okay, Gali, I'm gonna go to you in a second. There's a question from the chat. What about patients with mitral valve ring? It's a really interesting question. Would you go for TEER, edge to edge, or would you go for valve in ring?
It depends, because not all of them are the same. Let's say depend on the size of the ring. So if the ring is too small to put a clip, then there are sometimes 28 ring after functional MR annuloplasty, and then the chance of getting a stenosis even with one device is high. You have to look whether the ring is detached or not. If you have ring detachment, then it's not a good idea usually to go for valve in ring. Sometimes it's not uncommon that in recurrent MR after ring annuloplasty, the posterior leaflet is so retracted that you cannot do edge-to-edge repair, or the jet is so commissural that it's almost, and then you are forced. So if it is a good anatomy for edge-to-edge repair, I rather prefer to try at least to do edge-to-edge repair unless the annulus is really small. If the posterior leaflet is almost absent or completely retracted, the jet is completely commissural, or the annulus is too small, then I prefer to go for valve in ring, unless it is this geoform ring, this rigid ring where, you cannot do valve in ring because you cannot deformate them. If there is a ring detachment, I usually try for edge-to-edge repair, because, you may have further ring detachment. Even if the ring detachment is small, you can do it, but it could be dangerous. And then obviously you have to consider the risk for LVOT obstruction. There are now leaflet modification strategy, but obviously this make the procedure a bit more demanding, feasible, but you have just to plan in advance. You have also to consider this, the risk of LVOT obstruction.
Gali, one quick question, please, and then we'll see if Andrea and Faraj have a quick question.
Okay, so my question, thank you so much, Dr. Tamayaso, for the great talk. My question is the following, when it has to asbestos. So what is a good MitraClip result? Is it +1 MR or less than +1 MR, like in a very, perfect low risk patient? And based on your experience, what's the proportion of MR that is, recurrent or residual? Based on the numbers of cases you have done roughly, in terms of, you put the device and then you have residual or recurrent MR.
Yeah, it's a really good question. Actually, in ideal anatomy, we should target, I always try to target to 0 MR, obviously. It's not always feasible, but this is my target. But this is not always feasible. I think in off-label cases, like the one that has been published on Jack, that I assume were not surgical candidate. I mean, we have a lot of non-good surgical candidate where we can try to aim to 0, but we already know that we are not gonna obtain 0 because the anatomy is too complex, the valve is calcific. And in those cases, probably less than 2+ is reasonable. I always like to check at the left lateral pressure, usually in suboptimal anatomy, where I already know that is not a realistic target to go to 0. I target reduction of mean left lateral pressure. But obviously in ideal anatomy, especially if we want to treat low-risk patient, we should target to 0, at least. This is what we should aim. The period, the era where we were happy with 2 residual MR after MitraClip in a good anatomy is over. I mean, if you are not able to achieve in a predictable way 0+ MR or 1+ MR in a good anatomy, we should probably not do edge-to-edge therapy. We should refer the patient to another operator or choose another therapy. I think this is something that is becoming more and more clear. So the ideal result should be individualized to the type of patient. We have in the green group, we should aim to 1 or 0, and in yellow and red, we should aim to, we can accept something different. Regarding recurrency rate, unfortunately, there are not so many data or long-term results with MitraClip, and consider that the newest device, like Gen 4, and now the Pascal Precision, so the easiest device, they are not available since long time, so we are not able yet to have long-term result. Of course, the acute result is the main predictor of recurrent severe MR. So if we leave a patient with 2+ MR, the chance that he will come back with severe MR within the next 12 months is pretty high. If we leave the OR with 0 MR and good leaflet insertion, then the durability will be longer. And in those cases, usually, at least at the short and mid-term result follow-up, you don't see recurrency. If you leave the patient with some residual MR, this most of the time is gonna progress, unfortunately.
Yeah, the less MR, the better.
Yeah.
Andrea, Faraj, any questions? Mignati? Faraj?
Good morning, Dr. Latif. Thank you, Professor Taramasso, for this amazing talk. Just a general question about maybe more like a prediction. If we have the trials going on for designated transseptal devices, and if we will be ever have multiple devices that can fit for replacement, and if this happens, do you think will be a place for Clips or Pascal? Thank you.
In mitral, I think so, yes. Of course, edge-to-edge repair is probably not the most physiological repair, especially if we think in a surgical way, where edge-to-edge surgical repair has been criticized for many years, because at the end, you restore the function of the valve, but creating a totally different physiology. Nowadays, the Alfieri group published really long-term result of edge-to-edge surgical repair, and the long-term result in association with annuloplasty, obviously, but they are really good, or they are at least comparable to the Carpentier classical correction or the chordal implantation. So I think even if we don't restore the physiology and the anatomy, the function of the valve is somehow preserved in terms of also in the long term, possibly, and this will never be beaten by a prosthesis, because a prosthesis, you will have more risk of thrombosis, more risk of infection. You somehow fix also the basis of the heart, and so you may compromise also the contraction of the basal myocardium. I don't know, but also in terms of surgical thinking, there are no randomized studies comparing mitral repair and mitral replacement, because the result of repair are so much better in acute and long term that would be probably at least for DMR, unethical to do a randomization. For FMR, we don't know, but still, the safety of a MitraClip or a Pascal implantation is so high that I think there will be still a role, but they will be complementary. We will have patient for one and patient for the other one. I don't think one device will take over all the anatomy, even in FMR.
Thank you.
Yeah, I agree with you. I think, we all hoped, Faraj, what you're saying is something we all hoped. We all hoped that TMVR would be like TAVR and we'd be able to do it on every anatomy and it would be agnostic. But the thing we have to remember, I have to keep reminding myself, Mauricio doesn't because he's a surgeon too, is that everything that's percutaneous is not agnostic to anatomy. It's very dependent on anatomy. The only thing that's agnostic to anatomy is open heart surgery because you can cut it out and completely replace it. But, all we do with the transcatheter approach is agnostic, is very dependent on anatomy. That's the one. And then the second thing, the thing about MitraClip is it's just very safe. We get away with treating very sick patients who are very elderly, very symptomatic, and they're going home the next day. It's just not going to be the same with TMVR. There's going to be a whole set of new issues, whether it's how do we manage the interatrial septal defect, the venous puncture site, which is above 30 French, DVTs, bleeding, anticoagulation, lifelong afterwards. There's a lot of, a whole set of different issues. And then afterload mismatch. A lot of patients we treat can't tolerate getting rid of all the MR. So there's still a lot we got to figure out there. Last question, Andrea Mignati.
Yes, hi Maurizio. First of all,
Andrea.
congratulations for the great talk. It's I'm learning a lot from you. My question is very, very general, and it's, since we are also running out of time, is you're the surgeon, you see the valve, you touch the valve, you're able to touch the device and adjust it. General question is, what do you see the future of? How would you like the future to help you in getting this percutaneous procedure done as closely, if it's even possible, to the surgeon? Would you want to have better imaging? Would you have better tactile response? Would you have a better way of actually being able to place the the device? What is the most difficult thing for you as a surgeon in doing this procedure?
Well, probably a mix of everything. If I can decide, I would like better imaging, definitely. I would like easier device to implant, and would be nice to have enough data to really know which device, because we will have more and more device, and we will be always discussing, I prefer Pascal, I prefer MitraClip, I prefer TMVR, to have I know it's impossible, but to have some kind of guidance that make the field more standardized. I would like to have something different than surgery. There are many surgeons telling that in my hand, this valve can be repaired 100% of the time. I would like something that in every hand can be repaired 100% of the time. Something which is more scientific and reproducible and not just art or magic. I know it's difficult, but this is what I would like. So more predictability before and after, and something which is, if I do it in Switzerland, if you do it in New York, or if somebody is doing in Tokyo, like more or less like TAVI. At the end, TAVI is becoming really reproducible independently from. We will always be happy to be considered as expert in doing one procedure, but the future should be that one procedure should be done by everyone, everywhere, with same result and same safety profile in the ideal world.
I agree. Yes.
It's doable only with the mix of what you mentioned: better imaging, better training, better device.
I got to tell you, that's the if I think about the procedures I do in the cath lab, one of the hardest procedures I do in the cath lab is edge-to-edge repair, transcatheter, because every procedure feels like it's different.
Yeah.
And sometimes I go in and this is going to be so hard, and I put one device in the center and I go, oh, I'm done. And other times I think it's going to be a pretty straightforward case, and 4 hours later, I'm still there, right? And the predictability and reproducibility leaves a lot to be desired. There's a lot of thinking involved. And the one thing, Claudia's there, Edwin's listening, He's not on. I think he's traveling, so he'll get on. We'll see him later. But we can't do this without them, right? And you're very dependent on the quality of how good your imaging specialist is, right? If you have someone who's very good, who's running the probe and who understands the anatomy and has experience, your results are completely different compared to just having someone who gives you standardized views and you evaluate it. So there's so much left to be desired as regards to predictability and reproducibility. I mean, I don't know, Mauricio, I would love to get to a stage where we have like some software with AI and I just put my echo in and it goes, okay, in this case, you need to put 2 devices in the center, right? 2 wide devices, or you need to put 1 here and 1 there. And if I do that, that's what I'm going to get. I'm just not sure the mitral valve is ever going to allow us to do that. I hope it does. But with repair, you know, it's not that easy because also I'm surprised sometimes, Andrea, about how we have a result, it looks okay, and then I change something minute, right? I maybe grasp a little bit more posterior leaflet, or I change the orientation 5 degrees, or I move the clip 1 millimeter medial, and the result completely changes. I mean, a procedure that's so dependent on like implantation and getting the implantation at a perfect position is always going to be difficult to reproduce large scale. And I think that's why we all hope, you know, valves will take away some of that lack of reproducibility, but it's never going to get rid of edge to edge, I don't think. Mauricio's last final closing comment. Where do you see the future? So let's say if I ask you 10 years from now, okay, what is Maurizio Taramasso going to have in his hands to treat a mitral valve percutaneously? And what percentage of cases he'll use what?
Good question. I think probably 10 years is too early, but quite soon we will have some artificial intelligence helping us in selecting the different devices. I think edge-to-edge repair will be still available in 10 years. Maybe we will have more than 2 platforms, and we will have something which is more even more precise, like sensor to tell you how many millimeters of leaflet you have,
Exactly.
predict the gradient, predict the risk of afterload mismatch and whatever. We will have replacement for sure. We will have a transeptal replacement, and that I think in 10 years will be maybe not widely available, but available, and probably transapical will be reserved only to a really minority of patients. And then I think surgery will still play a big role for DMR, minimally invasive or even robotic surgery for low-risk patients. I think there are many surgeons that are afraid that, I mean, the interventional cardiology community is pushing the limit to, but I don't think this will happen. I think in 10 years will be, maybe there will be even more patients for surgery, and also because we will see the failure that we are treating now, maybe hopefully. And then obviously coronary implantation and annuloplasty, we will have more repair device. It will be much more fun and complicated to repair well a valve, and you know, it's gonna be extremely interesting.
Maurizio, thank you so much. This is like an awesome morning session. Thanks to all the fellows for all their great comments and discussion. I really enjoyed this and I learned so much. So thanks everybody. Grazie Maurizio.
Thanks everybody.